Welcome everybody. Now welcome Dr. David Kaufman. This is a second seminar in the series of webinars which we are running. And today I'm fortunate there are, along with the students, the 5 medical colleges also have decided to join, and lot number of students will be joining this particular session. Let me in brief give the, last time also I given the introduction. Dr. David Kaufman. He is basically infectious disease expert in the New Jersey area. He's a very large expertise into so many years working with the different organizations. He did his fellowship in the infectious disease from Medical College of Pennsylvania in 84-86. In fact, he did a medical doctorate from New York University in the back as 1974, and they did an internship into internal medicine, general surgeries, and a residency internal medicine from Georgetown universities. He has been working with the Inspira Health Network, the Cumberland Internal Medicine, Vineland, and he has been expertise working since 1978 into the medical field. Is one of the most prestigious medical professional in a New Jersey area. He has been handling large number of residency students. He was a part of interviewing panel for the residents, and he has over a period of time has nurtured the students part of it. He has a passion to really teach and mentor the students part of it, and a large number of our students, astute students, he will be mentoring. So we will be start sending the profile first for those students who will be joining in 2022 cycle, then 2023, and then 2024 cycle. So he will be helping into the profile building. So in the next webinar also we'll be talking. Today is be talking about the residency training in America, and that is going to go into much detailed into that. Last time we generally spoke about the education system, the hospital system in United States. We are really fortunate that such a experienced and senior professor doctors is available and to guide the students. And I welcome, and it is a privilege of Astute to have associate with Dr. Kaufman. So thank you very much, doctor. And we can now start the profile. You may add your profile part of it to this, and I'll be very, very happy to take the slides and other things of it. Thank you very much. You can start, Dr. Kaufman.
All righty. Thank you, Dr. Deoras. So that was Dr. Deoras's very nice way of saying I'm old. So I've been doing this a long time, and I'll agree that I do have a passion, as do many older folks, of passing on what they've learned to younger people. So my life has been spent as a physician. I am thrilled to see young people take up the mantle to be physicians and to take care of others in this altruistic profession. So it's really my pleasure to be here. So for those of you who were here for the last webinar, welcome back. To the new folks, welcome. And again, many thanks to Dr. Deoras for having me. We have a lot of ground to cover. These slides are designed a little bit differently from the last time. These slides are really designed as much as to be presented as to be kept as a reference. So we're just going to hit the high points of these slides. There are many of them. We're not going to try to read every word of every line. You'll be reading and I will be talking, and I hope they keep your attention. Okay, let's go. What you're seeing in front of you, by the way, was a very popular TV show in America. I know there are a couple of popular TV shows or ones that were popular in India dealing with residents. These guys are wearing the typical uniform residents in this country wear, which we call scrubs. I don't know if you call them scrubs over there, but those things that I like to call pajamas, we call scrubs. And that was the name of this show, Scrubs. So let's go to the next slide. Okay, so this introduces one of my themes, and what I'll say is a lot of what I'm going to be telling you in the take-home message is that when we talk about application for residency in a country other than your own, in this case, the United States is what we're going to talk about, or I'll also refer to it as America, is it's like cricket. There are rules, there's a certain culture to it, and if you don't know the rules, you put yourself in jeopardy of not achieving your goals. So a lot of what we're going to talk about is the culture and the rules here of application and the rules of residency to some extent. I'm not trying to make you feel any more an underdog than you may feel already, but you're going to be competing against and then hopefully teamed with doctors who have been raised in the game. So just like I'm going to be coming to India and I'm going to be going to a cricket match, I don't know the rules yet. It's going to be very obtuse and obscure to me until I know those rules. So I want you folks, and I'll be calling you guys. I want you guys, which means you guys and girls, you men and women, to begin to learn the rules and the culture. If we succeed in what we do, what I really want to come to with each and every one of you is that you're familiar with the system and that you trust the system so that when you enter the system as an applicant and as a participant, as a resident, you trust the system. And what I mean by that is you'll feel like your application is being fairly evaluated. You are being fairly evaluated, and where you wind up in residency is kind of sort of where you were meant to wind up, and it's a good place for you. That's what I mean by trusting the system. Let's go to the next slide, please. Okay, so the take-home message here is understand the system. Take the time to learn it well. For those of you who are in your first year, start now. And everyone who hasn't started, turn off this webinar and start now. Okay, to do your best in this effort in your life, you're going to have to know yourself. You're going to have to know what you're looking for. You're going to have to then know what they are looking for, and that you're going to trust that the system will find the best place for you. I firmly believe that that is true. All right, let's go to the next slide. Okay, so this is about me. Dr. Deoras has already made me sound far more important than I am. What I would draw your attention to here is really three things. Number one, I'm old. I've been doing this for a long time. My passion has been internal medicine and infectious disease, which should tell you all that really I'm a diagnostician above all other things. And pay attention, please, to the last line of this. I'm honored to be the coordinator for United States medical training for Dr. Deoras's very own Astute Academy. And I cannot begin to tell you how excited I am to play that role. Let's go to the next slide, please. Okay, so what we're going to look at is we're going to look at the structure of the residency. We're going to look at the application process, what we call the match, and then we'll spend a few minutes talking about items of special interest to international medical students, medical graduates, or what we'll call IMGs. Used to be called foreign medical graduates. So if you read older stuff, that you'll be identified as foreign medical graduates. What we are not going to discuss is the very personal issue of how to choose a career path. And once you choose your career path, how to choose the best residency for you. Those are long and individual processes. We have lots of help at Astute Academy for that if you need the help. And that is just not something I can cover in this webinar. Let's go to the next slide, please. Okay, so the first question I would say, approaching this logically, is why would you do a residency? So when in my slides you see things, when you see font in italics, okay, it generally indicates, as it does here, that this is a quote. So this is from the ACGME, the American College of Graduate Medical Education, who is in charge of all residency programs in this country, the United States. And this is what they have to say about why you should do a residency. And I agree with it completely, okay? So it's that step in professional development between medical school and being able to function autonomously as a physician. It's a time for you to transition from being medical scholars to physician scholars. And it is the time in which you are shaped to be the doctor you're going to be for hopefully the rest of your life. Now, all that's well and good, no surprises. What I've underlined here is a few key words, okay? Excellence, compassion, professionalism, scholarship, diverse, educate, equitable, and health of the populations. So what I'm going to tell you, and this is going to be really what webinar number 3 is about, what I'm going to tell you is when I was a young man and when I was entering medical school some 50 years ago, the important thing, the expectation on the part of everyone was that you were going to be able to assume the extremely difficult task of learning normal physiology, anatomy, etc., and then learning disease, etc., and learning how to apply that to patients. That is an immense fund of knowledge. However, given many changes, which I could spend an hour talking about, this is not enough anymore. So there is a belief in this country that many things that we would previously describe as attitude or givens or things that were innate can be taught, such as compassion. There is a message in the second bullet that there is an awareness in the United States that medical care has not been equitably distributed, that there are marginalized populations, as I know there are in India, who do not benefit from the kind of medical care that others. So you see in there's a diverse community. There's a recognition, and the word equitable. There's a recognition that physicians are going to have to teach the new physicians. So your residency is supposed to be designed to educate you to educate futures. We're going to teach you to fish so you can teach everybody else to fish, for those of you who like Confucius, okay? And then in the last paragraph, you'll see there's a recognition that by taking care of individual patients, you should begin to understand that what you're really doing is taking care of certain populations of people. So there's a lot of nuance in this particular statement that I want you to recognize. And as you read about these things and listen about these things, listen for those words. You're going to see them repeated. That's my dog in the background, so say hi to Rupp. Okay, next slide, please. Okay, so now we finish this glorious idea of education that sounds like it came from Plato or Socrates. But the real truth of the matter is, for those of you who are more practical, you do a residency because you're not going to work as a physician in the United States unless you're fully finished with a residency. And that's the fact of the matter. And even if you could, after 1 year of residency or graduating medical school, you would never get malpractice insurance. And if you can't get malpractice insurance, you're not going to be able to see patients for any insurance company. So if you want to be a doctor in the United States, you have to do a residency. Let's go to the next slide. Okay, so here is the breadth of opportunity slide. So this is the list of different residencies. There are actually a couple more that I didn't list, but these are the major residency tracks in the United States, okay? These are all the things that you can train in. So if you're quick with your math and you add these numbers and the numbers I didn't put up, there's over 39,000 spots a year open. There are about 28,000 plus U.S. medical graduates. So there's a lot of opportunity both for practice in this country, for international medical graduates, which include United States citizens who train abroad, and citizens of other countries who are training in other countries. There's lots of spots available for them. So in parentheses, just so you understand the slide for sure, this is about the number of spots that were open in the 2022 or 2021 residencies listed next to each of the items of residency. Okay, I want you to turn your attention to number 21, which is what's called a transitional path. This is where you do training in very different things. You might spend a month in radiology, a month in pathology, a month in the ER, and this is in preparation for training in one of the other residencies in which you could be board certified. Okay, next slide. I think Dr. Deoras failed to mention, sorry, Tushar, if you have any questions, post them in the Q&A and we will get to them at the end of this. So a quick word for you, okay? Quick 3 words, actually. Categorical, preliminary, and advanced, okay? A categorical residency is, an internal medicine residency, 3 years, at the end of which you are eligible to take the board exam from the American Board of Internal Medicine and become a boarded internist. A preliminary residency is a year you're going to spend usually doing internal medicine, sometimes doing that transitional path we just talked about. So then you can do your categorical residency in radiology, neurology, dermatology. So you don't go from medical school right into those residencies. And then an advanced residency is those we just mentioned. So for certain programs, if you apply to be a resident in dermatology, you're applying for your postgraduate year number 2, and you need to get a preliminary residency for that first year. However, some of the advanced residencies pair with a preliminary residency, so you only have to file 1 application. Okay, next slide, please. I hope everybody understands that. Okay, here's the structure of residency in America. Residencies last from 3 to 5 years. Surgical residencies tend to last 5. Internal medicine, family medicine are 3-year residencies. There is a huge variation in the size of residency programs. Some of them have a total of 3 residents, meaning they take 1 new resident a year. Others of them will have more than 160 residents, say, for internal medicine. Okay? There is a huge range of settings for these, not only geographical, which we're not going to talk about very much, but you can train at a 1,300-bed university hospital that sits right next to the medical school, or you can train in a rural clinic that has 16 inpatient beds or is connected to the county hospital 20 miles away. So there's a huge variety in sites you can train. Okay. For most residencies, most of them, clinical experience is disproportionately inpatient. Practice tends to be more with outpatients for most of us, okay, but training tends to be with inpatients. As a resident, you're going to take care of patients in the hospital, doing daily patient care. You're also, it's not listed here, going to have in some variety, clinic patients, outpatients who you see. In your outpatient rotations, you're going to handle admissions to the hospital, discharges from the hospital. You're going to integrate patient care with residents from other specialties, attendings from other specialties. You're going to have to arrange follow-up outpatient care. So you're going to learn how to take care of patients. And the main thing you're going to learn is how to take care of sick patients. Okay, let's move to the next slide. Okay. So as of, I don't know how many years ago, sorry about that, residents are limited to an 80-hour work week. This was done because of some exposés of medical errors. What has remained unclear is whether the 80-hour work week has saved us from some of these medical errors or just translated them into different types of errors. My particular bias, for whatever interest it is that we're still making the same number of errors. They're just different errors than we used to make. Okay, there is a regular rotating night schedule where you would handle late admissions from the ER, anything that comes up with a patient on your team acutely during the night. Disease doesn't take a holiday, doesn't follow a calendar, doesn't have a 8-hour work day. You will be trained to do the code blue, which means cardiac arrest and other emergencies in the hospital. Most residency programs limit how many patients will be under your direct care. Many training programs have a mandatory research project. They generally take one of the 2 forms I've outlined there, a process improvement thing or a chart review where you look at the experience of patients in your hospital, had a certain procedure done or whatever, and you reflect on that. Annual residency salary is about $61,000 across the years of training. in the big cities where the cost of living is higher. It may be higher than that, it may be a little lower than that in rural areas, but it rounds about to that. All residencies are structured as increasing exposure to different specialties and increasing patient care responsibilities. Let's go to the next slide. Okay, so this is the typical structure of an internal medicine residency. You can look at it at your leisure, and what you'll see is as time goes on, you spend a little less time doing primary inpatient care, in other words, being captain of the team, and you spend about the same amount of time in the outpatient clinic. Usually in your first year, you'll spend some time in the emergency room. You'll spend a lot of time in the intensive care unit and a little less time as time goes on. And you'll see in the middle row there that says elective is where you'll spend more and more time as time goes on. So you might have this, by the way, is in weeks. I should have written that someplace. Sorry about that. This is how many weeks out of the 52 weeks of the year you might be spending. So in your first year, you might spend a week or two in cardiology or infectious diseases, but by year 2, you're going to be spending 22 weeks doing training with the subspecialists. Next slide, please. Okay, so this is a typical day in the life of a medical resident. It says here you'll be getting to the hospital between 6 and 7:15. Frankly, the medical residents, I know, tend to be a little bit more towards the 7:15 side. Okay, regular morning activities are receiving patients from the teams that have been on call, from the members of your team that have been on call, who will tell you what's happened to patients and about any new admissions. You'll be dividing up those new admissions, and you'll have morning report where you meet with an attending or a chief resident to review admissions from the night before. You'll be doing chart review from, these numbers are for sure made up, but from about 8:15 to 9:30 or 10, you'll be reviewing charts, visiting your patients. Most people will be writing preliminary notes. What do we know now? The lab work is usually back in by then. I saw the patient, this new problem, what's happening with the old problem. Then for the next 2.5 hours, the team will make rounds. At lunchtime, you generally have 15 minutes for lunch, and then there's some formal didactic, which in internal medicine is usually an hour lecture by an attending, sometimes by another resident, often subspecialty sort of stuff. So you'll hear a lecture from the infectious disease guy about blood cultures. That's the last lecture I gave. Okay, in the afternoon, you'll be handling new admissions, discharges, et cetera, and you're usually done at 5 or 5:30, and late in the afternoon, you usually have protected time for an hour to do things you need to do or to attend certain regularly scheduled things. That might be things like board review. Most programs have a simulation lab where you can go through different clinical scenarios or procedures, journal club, things like that. Next. So this is this is 2 days in the life of a general surgery resident. They get in earlier. And let me tell you, they get in earlier than the medical guys do, no question. They'll make rounds first thing. They might have an early morning didactic. And then you see 2 days in a row, all color coded for you in red, because you have to be in the operating room. You're not just learning about illness, you're learning about surgery. So you're learning science and craftsmanship. Surgical residencies usually are about 5 years, general surgery residency. There's your outpatient clinic, maybe one afternoon a week. There's a list on the left of some of the didactics available to you, and these are regularly scheduled by your program. Generally speaking, I'll just mention, if you interview, you'll attend one of these to get a sense of what goes on in the program. It's always a good idea. Okay, next. Alrighty then. So once again, you're not only expected to become an excellent, or shall we say superb physician, because you understand disease, you can diagnose and treat. In the case of a surgeon, you can take someone in the middle of the night and do the finest bit of handiwork possible. That's not enough. So besides patient care, medical knowledge, and practice-based learning, pay attention to what's in red. You're going to be graded and trained in interpersonal and communication skills. You're going to be judged on your professionalism, and you're going to be taught what someone came up with the brilliant name of a system-based practice, which is another way of saying, and forgive me if I'm a little cynical about this, I'm someone who believes that it is an incredibly wonderful and noble thing to be a physician and to be an excellent physician. Include some of these items, but I was brought up to think that these are things that you would sort of absorb from osmosis, from seeing other doctors, but now they tend to be taught more. And this is a big part of the change in residency program. So systems-based practice really reflects the fact that many physicians now are employees of hospitals or bigger systems, and they're really training you how to be a good employee. So all of this sounds cynical. I will tell you that every good residency program I know spends 90% of the time on what's in black and fills out what's in red as best they can. So I don't want you to be intimidated by this or misled, but these things will be included. They're what we call in this country buzzwords. You know, everybody who's in medical administration and medical education knows what professionalism means. Okay, next slide. All righty, so this is, for example, there has been an effort in this country to make residency training more uniform. Okay, so there are tests that everybody takes, and there are what's called milestones that you're supposed to reach at a certain part of your training. So this is part of surgical training. This is the second section of patient care for a surgeon, which is intraoperative patient care, performance of procedures. And here are the 5 levels they talk about. Basic skills like knot tying and suturing, all the way to being able to do a total pancreatectomy or a Whipple procedure, or remove someone's esophagus and reconnect the stomach with what's left of the esophagus. And you'll notice at the bottom, as you go on in residency, you are supposed to be able to teach these to people who are coming after you. One thing to pay attention, just to make an editorial comment, and I really want you to pay attention to these because they're based on a lot of experience. One of the things you'll look for, especially as a surgical resident, but also very much in anything, is what is the quality of resident to resident training in the program you're looking at. It's not something that's easy to measure, but it's something you can observe when you visit the program. Next slide. Okay, so again, back to, there is an effort to regularize training. So everybody in America is going to take an in-service exam, first year, second year, third year. Same exam is taken. Programs expect you to show progress, so your grade should be going up. And I will say they tend to be very predictive of who's going to pass their certification boards when they finish their residency and who's not. So there's some programs will train a lot specifically for the in-service exam. Others will suppose that because they are just such wonderful programs and you're such very brilliant doctors that you are going to pass these in-service exams. Something else to look for as you distinguish one residency program from another. Next slide, please. So the in-service exams are used in 2 ways. They're used to look at each resident, make sure you're coming along, identify areas for specific remediation, and the same thing, and probably more importantly, for the program. We want to know, is our program a good program? If we're starting out, everybody at level 1 is getting this grade, and on the second year, they're getting the same grade. We're not doing a very good job here, and we're going to have to change that. So that's the use of these in-service exams. Next slide. So the take-home message here is that residency training in the United States is highly structured. It's characterized by increasing emphasis on standardizing resident teaching and following resident progress. You are formally taught and supposed to understand the academics, the ethics, what is meant by professionalism, and how to function within the system of healthcare. And what I'm going to tell you in red and in italics is that the well-informed applicant presents herself. So this is a big deal, by the way, in America, what pronouns you're using now. So I'm going to use him, her, he, she, because we absolutely welcome diversity in our medical students and in our physicians. It's a very important thing. So the well-informed applicant presents himself, as already having adopted these values. Okay, I'll say that again. As you go along in your medical school, I want you to begin to be aware of the ethics you're learning, what it means to be professional, and we're going to spend the next webinar is going to be all about these things and things like them. Okay, and by the way, I try to include obviously some images that are from a country that's not mine. So I'm trying to move into that culture. I have not yet visited that country. I will be visiting in the fall, and I can't tell you how excited I am about that. But if some of these are not appropriate, accept my apologies and understand that these are the hazards of moving from one culture to another. You make many assumptions which are based on your culture, which may not be true for another. So on to the next slide. Okay, so we're done with describing residency training. Once again, I don't see any new questions in there. So if you have any questions, please post them. Okay, so residency application is a step-by-step process for both the applicant on the left of the slide and the residency program. For the applicant, there are at least 2 exams and probably 3. This is something that is changing right now, and we'll be spending a lot of time talking about when people are going to be taking the USMLE clinical knowledge or Step 2 CK exam. So you're going to have to take the exams. You're going to have to assemble and submit all the required information to the ERAS. We're going to talk all about that. You're going to have your next step indicate the programs you're applying. Then you're going to interview to the ones who select you. Then you're going to make a list from number 1 on down in order of your preference of what programs to go to. For the residency programs, they're looking at all these applications. They choose whom to interview. So that's what we would call the first cut. They would take all the folks they interview. That's the second cut. Some of them they're not going to list at all. Most of them are going to be listed in their rank order list. ROL is the way that's abbreviated. And then they, like you, will await the results of the match in March. Okay, next slide. Okay, so the application process. All applications are done through the Electronic Residency Application Service, ERAS. So this is a jungle of acronyms, this whole business, but I'll try to make sure I cover all of them. ERAS is sponsored by the AAMC, the Association of American Medical Colleges. Almost all residency programs are going to interview you either in person or virtually. I'm going to give you a very strong recommendation that if it's at all possible, that you interview personally for the residency, and we'll see why in a little bit. Interview season is late September to early January. It's mostly October, November, December, and then the program and the applicant lists their choices in the orders of preference. There is a couples match for people who are married or want to stay together. I'm not going to go into that in great detail. And programs then which do not match all their position or candidates that do not match the very next week after the match have an opportunity to fill their places in what's called the SOAP. And we'll have a slide about that later. Let's go to the next slide, please. Okay, so ERAS, okay, the Electronic Residency Application Service, is brought to you by the ECFMG. It's sponsored by the ECFMG, the educational, or it's co-sponsored, the Educational Commission for Foreign Medical Graduates. Let me make this clear so there's no confusion. Both international medical graduates and United States medical graduates, both MDs and DOs, if you remember the last talk, all are applying through ERAS. Okay. But for the foreign medical graduate, you have to have a passing grade in the occupational English test, the OET. You're going to have to have taken the USMLE Step 1 exam you're going to need a curriculum vitae or the equivalent of that. You're going to need letters of recommendation, personal statements, medical school transplants, medical school transcripts. Excuse me. I don't know why I have my mind on transplants this morning. I don't need one, as far as I know. And I don't know how Dr. Deoras feels about this. I believe you're going to very soon have to have taken the USMLE Step 2 CK exam, and we'll talk about that in just a few slides. Next slide, please. So this is the OET, the Occupational English Test. It was designed by a bunch of folks in Australia. This one is, there's one specifically for nurses, there are for other professions. The one you'll take will be designed specifically for physicians. Most of you, I'm sure, will be taking it digitally at home, but there are testing centers you can take it digitally, or you can take it on paper. Okay, it is valid for 2 years after passing it. So just one of those nice little facts to know when you're planning your timing. Okay, and in that website, I list below for you. And again, these slides are yours to keep, and they're meant to be used as a reference. This particular group in Australia, I think they're the Cambridge group, has excellent preparation for the exam for you online. Next. So a little bit more about the OET. It involves listening, reading, writing, and speaking. If you fail one module, it can be repeated individually. You don't have to take all the modules if you don't pass one, and the details are all there. I don't think there's any reason to go into them in great depth. I do have in red on the right lower quadrant, if you will, of the slide, that you are graded in speaking on intelligibility. I will tell you, and Dr. Deoras will tell you, I'm a very frank person, because nothing I ever say to anyone I am mentoring is meant personally to hurt feelings or anything like that. But one of the things I will tell you is, having been on numerous application and interview committees, if someone's speech is very hard to understand, that is an obstacle for them. And it's an obstacle, if that's true for you, then it's an obstacle that you can address, and with some work, you can overcome it, and it's not a big deal. But interviewing somebody not being able to understand what they say makes it very hard for you to rank them high. Next. Okay, so we're going to go over some more details about these things. I want to talk to you some, and I'm going to spend some time talking to you about letters of recommendation. Now, I don't know, but my colleagues at Astute Academy most certainly know this. I will tell you, in the United States, there is no obstacle. It would not be offensive. It would be considered routine for me to approach somebody and say, Dr. Such and such, I'm applying for residency training in the United States in internal medicine. Do you think you can write a strong recommendation for me? That would be de rigueur. That would be just what you would do. And if that person were to say yes, which they usually do, you might say to them, in the United States, again, I don't know how appropriate this is in India, but if you're seeking recommendation letters from after having spent some time here in the United States, you might say, in all honesty, I think this really required me to be a good, reliable team member. I hope you'll feel confident mentioning that, or something to that effect. When you start an activity or a project, and you'll have many of them during your years in medical school, both inside the medical school and outside, begin to think of choosing individuals early on that you might have to write those letters of recommendation for you. Skip that last line. That's kind of a reach. Okay. Every medical school is going to have a letter from your dean. I'm going to tell you that studies in the literature show that unless your dean really knows you, that paragraph is just passed over. Research also shows, and I've reviewed all this literature, I assure you, the impact of a letter of recommendation is strongest when the author is, if you're applying for thoracic surgery, if the person recommending you is a thoracic surgeon, that's a stronger letter right away. If that letter reflects a strong relationship, a close relationship, someone the writer really knows, that's a stronger letter. If it should focus specifically on a few traits rather than say, Dr. Alka Farmer is very nice. That I can tell you that goes nowhere. And then whoever writes your letters, it's always helpful if a specific incident, I remember when this happened and the person I'm recommending did this, and that's a good illustration. Actions are always louder than words. Okay, next. Okay, we're going to talk a little bit about the USMLE exam. So this above in italics, once again, is a quote from the people who write that exam. This is what it's meant to measure. You'll see some italics in red, lifelong learning. So this is a big deal. Now, one of the criticisms of U.S. physicians have been that they don't keep current. So now your residency program is going to spend time preparing you to do lifelong learning. I'm, once again, apologies to all of you, I'm a little cynical about whether you can really teach somebody to be devoted to that. I like to think that you teach people to be devoted to that by setting an example for them. I don't think sitting them down and telling them you need to be devoted to lifelong learning is going to do a lot. Now, in bold, take-home message, the USMLE exam as of January of this year, which is to say 5 months ago, is a pass-fail exam. You no longer get a numerical grade, or may I say more correctly, no one you're applying to, nor does your medical school get a numerical grade, okay? There was a typical time. This is taken by students. That may well change and become earlier. In terms of the mechanics of the test, there are 7 one-hour blocks. There's an hour of scheduled breaks. You can take your breaks at the end of the block. You can take unscheduled breaks. There are all kinds of rules about what you may have there and what you may not have. Obviously, you're not allowed to have a cell phone with you. You're not allowed to talk to other people during the break about the exam, et cetera, et cetera. There's a great fear on their part of people remembering exam questions, writing them down and passing them on for study guides, et cetera. The questions all present a clinical case. A 37-year-old woman presents with chest pain. She tells you it's worse at night. It's not bothered by exercise. It's located in the middle of her chest and also occurs after eating. And they'll say, what is the next appropriate thing to do? So that's what I mean when I say it's clinical case-based. There are some audio portions, less in step 1 than in step 2, like cardiac auscultation. A passing score is pre-formulated, so it's not like a fixed number of tests, a number of questions passes each year. It varies a little bit, and the percentage of people who pass each year changes. Generally, and we'll look at pass rates, but generally speaking, if you answer 60% of the questions correctly, you're right. You have a digital tool that helps you strike incorrect answers as you come across them. You have a clock you can activate there that'll keep track of your time. And you have a means of flagging questions that you're unable to answer right away so you can go back to them. Very important. These questions are all multiple choice. There's one correct answer. What we say in the United States, I don't know if you use this expression in India, there's no penalty for guessing. So your score is the total number of correct answers. Nobody's subtracting for incorrect answers. So in other words, you answer all the questions. Okay, next. Okay, so the next few slides are going to describe by system here what the test is about. So 9 to 13% of the questions are about endocrine and reproduction in this particular example. Next slide. Test is also described to you under areas of physician competency. So 6 to 9% of the questions here are going to be communication and interpersonal skills. So one of them might be a woman comes to you and is complaining about severe vaginal pain. Exam reveals blisters, vesicles. diagnosis is herpes, and they'll give you 5 statements to make to the patient and ask you which is most appropriate. So that's a communication and interpersonal skills question. Next. Okay. And then they break it up a little bit differently. And what I would say is this is about what course you would have learned the answer to this question in. Okay, next. I don't want to spend a lot of time on this. Okay, so here are your pass rates, okay? And you'll see in front of you 4 lines. And boy, these colors did not come out as well as I had hoped. And apologies to the presumable 40% of the males looking at this who are colorblind. But the top line here, my son is colorblind, my younger son. He's an orthopedic trauma surgeon. He did okay. All right, so United States medical school graduates are going to pass the USMLE right up around 96 to 98%. The next line down, boy, these labels got moved. I'm really sorry. This is not a good slide. The next line down, which is the blue, is your international medical graduates who are passing. There's actually been a nice improvement. It used to be 77, 78%. It's now 81, 82% pass rates for international medical graduates. The 2 lower ones are for people who failed the first test and have now had to repeat it. So that'll give you an idea of percentage of pass rates. Next. Okay, and this is if you pass, they'll show you kind of how you did within each area. Okay, next. Okay, this is the report you don't want to get because you didn't pass. It will show you your score, which is in that shade of orangey brown at the left. It'll show the minimum passing score, and it'll show you the distribution of scores in the higher performers. Okay, next. Okay. So now that I've scared you at the idea of not passing, do understand that at the end of the day, 80% of those who fail step 1 will eventually get residency training. So it doesn't mean that you give up being a doctor. It's not that, but it does delay you, and you want to pass. Trust me on that one. Okay. Unfortunately, if you don't, this is the kind of report you'll get. It will tell you where your weaknesses are. Next. Okay, before we go to this slide, I'm going to go off the slides and give you an editorial comment. If I were going to school in India and I wanted to train in the United States, I would have as part of my regular study, I'll say it again, I would have as part of my regular study one of the 2 or 3 leading books for USMLE preparation. And as I studied those subjects, I would be looking at those questions. I don't have a vast experience in this. I did not do this myself. I will tell you, my younger son went to medical school at Harvard here in this country. And he wanted to do an orthopedic residency, which, as we'll see, is a very competitive residency. And this is exactly what he did as he learned his courses. And I will tell you that it was brilliant on his part to do that. And you can not prepare any better than by doing that. So that is a personal and strong recommendation, which I can't document statistically, but that's really a good idea. Okay, so what are the implications of the pass-fail system? Well, that score was clearly in every survey the single most used tool by residency program directors in choosing who they were going to interview and choosing who they weren't. And once they interviewed people, a lot of people come out pretty much equivalent, right? On an interview and all that. Yeah, similar this, similar that. This was often what we would call the tiebreaker for how people were ranked. Now we have program directors and committees having to work way, way harder to wade through a lot of much more personal stuff that we'll take a look at. And it's frustrating for them because it's more subjective. And frankly, at a place like a community hospital where you're asking for people to volunteer to review applicants in this, it's a lot more work than when you had numbers to work with. So this is called holistically evaluating applications. It's much harder. It's much more time consuming. And frankly, it's probably for many people less satisfying at the end of the day because you're never sure because it's so subjective. All right, next. Okay. So some people think that this is favorable to the international medical graduates. One of the problems international medical graduates are going to have is that there's going to be a bias on the part of many program directors feeling, listen, we're a little more secure. We're a little more secure taking people who have been part of our system, who are American medical graduates. And if you took that IMG test and you had a really high score, man, that answered all the questions. That put you right in the pool. Now you don't have that opportunity. On the other hand, nobody else is showing a great score. So everybody starts off a little more even in the pass-fail system as long as you passed. Okay. However, on the unfavorable side, if you don't have something that we think of as objective, I don't think it's really objective, but it's nice and easy. It's a number score. If you don't have that, you're going to have other things that creep into your analysis that may not belong. So if you don't have scores and everybody's a pass that you're looking at, maybe you're going to think, you know what, we've had good experience from students from this medical school or these medical schools, so let's focus on them. And that's not in your favor. A lot of these things have not yet been analyzed statistically. I'm just making guesses here because this is new, this new pass-fail thing. Okay, next. Okay. Once again, we're back to cricket when we talk about the rest of the ERAS, okay? Everything has a lot of rules to it, a lot of cultural elements to it. Okay, what I'll tell you about your curriculum vitae, and there is no more strong recommendation I can give you, is that this is a formal document. There are rules about this as there would be rules for writing a symphony, okay, or playing cricket. And it may be very difficult for you to know the rules, and seeking outside help with your CV or with the equivalent of your CV may be a really good choice and allows you to focus your time on learning all that science you're going to need to learn. Okay, next. Oh, by the way, the curriculum vitae is also known in this country, we call it a resume. I know certain of your countrymen call it a resume, but in this country, we call it a resume. But they'll know what you mean if you say resume and CV, that's easy. Okay, so in addition to your CV or its equivalent, you are going to have a personal statement. View this, this is essentially an essay you're going to be writing about yourself. It is an opportunity to distinguish yourself in a large group of intelligent, high-achieving, ambitious young people, i.e. people just like you. Okay, it is your chance to present yourself as an individual. It is the next best thing to your personal introduction to your prospective employer, mentor, and teammates. Okay. Now, I will tell you different program directors, and this is not my opinion. This is well documented in literature, in surveys of program directors. The personal statement has a very variable impact on program directors. Some people love it, and it's very important to them. Some people, it's not. Here's my advice for your personal statement. And I cannot say this more strongly. I ran out of room on this line for the word always, but always, always, always be yourself. Okay, be authentic and sincere. You're allowed 4,500 words. Do not take 4,500 words. Nobody's going to read them. Okay, plan for 850 to 1,000 words. Be prepared to be questioned about items in your personal statements when you go to interview. Show your personal statement to your most brutally honest friends, your friends who are going to say, this really is not good. and ask what they think. And once again, your counselor should be of immense value in helping you with this. He's not going to make you more authentic and sincere, but he's going to help you with the presentation of this in writing. Next. Okay. So now that they made the USMLE Step 1 pass-fail, they have to give people more room to give more information than their transcript and their personal statement. So there's something new called the supplementary application, okay? So there are new questions that help you showcase your interest and experience, okay? They will help residency programs understand your interest and experiences and how they align, how those things align with the program environment, mission, and goals. Some very fancy words, so obviously they're not mine. That's a quote. Okay, this is separate from the ERIS application. It's been on a different calendar now. I doubt that's going to remain that way. My guess is it's all going to be on the same calendar very soon. You can opt to participate or opt not to participate. If you opt not to participate, either you better be pretty sure that you've got a residency lined up, or your application includes a Nobel Prize in something, or you're an Olympic athlete, or something that's going to for sure get you that residency. Program participation is also optional, but I think most programs are going to feel they need to do this. Okay, and you can see for this year, all the different areas that are participating in this supplementary application. So there are three parts to it: experiences, geographical preferences, and program signals. So we're going to talk about these each now. Next slide, please. Okay, so you get to talk about up to 5 experiences, okay? These are not my words. These are all quotes. Actually, they're not. These shouldn't be in italics. My mistake. Okay, what I would say is picture yourself as the program director. Picture what your application looks like to someone else. A very, very important talent to learn. Okay. Any questions as to whether you're going to be able to do your job as a doctor or function on a team of residents with their residents already in place? This is an opportunity to reassure people. It's an opportunity to tell people what you're passionate about, etc. The upper one is a quote, okay, aligning with program goals, etc. Okay, so these are things that you've been through that are important to you. And you have to tell everybody about them in 300 characters. Next slide, I'll show you what that is. Okay, then you also have an opportunity to present impactful experiences. So something like that might be you went to serve at what they used to call a leper colony. You took part in a clinic for an underserved population in India or in this country or in another country. What was your experience? How did it change you, etc.? The impactful experiences, again, these below that, family background, financial background, this is something that's very much used by people to present obstacles to them. I grew up very poor. No one in my family had ever been to college, never mind medical school. Okay, so these are optional, and you get 150 words to tell people about your impactful experiences. Okay, research, by the way, shows that this part of the application is more used by applicants from underserved ethnic groups and by foreign medical graduates than it's used more extensively by those groups than by American medical graduates. Next slide. So what I want you to understand, but this looks, oh, that's a duplicate. Let's move ahead. Oh, sorry. My fault. I'm getting tired. Hope you're not. Okay. I just wanted to show you that text in red, Remember, you have 300 characters, that's 319 characters. So when you explain the significance, it's a very pungent statement. You don't have a lot of room. Next. Once again, here's a layout of things that might go in past experiences, the type of experiences you might be reporting, something having to do with social justice, something having to do with some technology that you worked on with someone, a basic science project, a community outreach project, something that demonstrated that you were interested particularly in customer service or healthcare administration. Okay, and then this is just sort of a formalization of things to make sure they have sections to ask you what was your title of your position, the name of your organization, etc. Okay, next slide. Okay, and here are the key characteristics that people are looking for, and this is not my list in italics. These are quotes from the people who create this application, the ERAS people. As you look at your experiences, look at the ones that highlight one of these traits. And of course, as intelligent folks, as you read about these traits, you'll understand that these are traits that are now identified by American medical scholars as important to being a great physician. And we're going to spend a lot of time talking about this. This is what webinar 3 is about. Next. Okay. Another section of the supplemental application is your geographic preference. So this slide probably took me as long to prepare as any 15 slides because I had to color in. I was never very good at coloring books when I was a kid, and I haven't gotten any better. But these are the 9 geographic areas of the United States that it's divided into on your application, and you have an opportunity to list those areas in order of preference, 1 area or 9 areas in order of preference. And additionally, do you want to train in an urban area? It's kind of funny. They define that as a population of greater than 50,000. I wouldn't have done it that way. Or a rural area population less than 50,000, and why? Program directors have seen this for a year, and those that talked about it said they were kind of split as to how important this was. And frankly, it's a new item, and many applicants, their list of programs didn't really reflect what they said was their geographic interest. I would try to keep these two aligned. So that's a tip from me. If you say you want to train in the Northeast, which would be pink, okay, up there in the upper right corner of the United States map, then that's where you should have the most applications in. Next. Okay. This was the single thing that was most used by program directors, and it's called program signals. So in the old days, I can tell you when my son applied for orthopedic residency, he was coming out of Harvard Medical School. He had super great grades on his Step 1 exam. So he was kind of a hot item. So after he interviewed at the programs, he got a couple of phone calls from chief residents, one from a program director that said, hey, we just wanted to let you know it was really nice to interview you. We're considering you really highly in our program. So there was a lot of encoded language to try to get the candidates you wanted. Well, the match doesn't like that, nor should they like that. It's kind of cheating a little bit. So they did something that I think was very smart. In its place, what they did was within each specialty has a certain number, and you can see the numbers next to them. So orthopedics lets you give 30 program signals. In other words, in your application, at some point you can say, listen, I'm really, really strongly interested in this program. I really like this program. OBGYN has gone so far as to have 3 gold signals and 15 silver signals. So take that however you want. But this program signaling, program directors have said this was very, very powerful for them as they look at all these applications, quote, holistically, try to pick out of a group who's the best to interview. And it was very useful to them in choosing whom to interview, and then after interviews and creating their rank order list. So take great care in your program signals. And this is something that if you have a counselor, you'll get a lot of help with. And if you're having trouble doing it, get help. Next. Okay. So there is also USMLE Step 2 CK Clinical Knowledge Exam. This continues to be numerically scored. How long that's going to continue to be the case is unknown. Basically, it's a slightly longer test than Step 1, but is built along the same lines. There's a little variation in this test. They might present a case and take you through the case, and you'll have to answer one question, and then you'll get more details based on that answer, and you'll have to pick something else, et cetera, et cetera. But basically, it's the same kind of test. It continues to be numerically scored. I have not spoken to Dr. Deoras, who may have more inside information than I do. I'm going to think that programs are going to want you to have taken the USMLE Step 2 exam before they look at your application, so they have that result. That's my opinion. It's not law, but I think it's going to be, as long as this test is numerically scored, because if I'm a program director, I want a number to rank people on. I just want that. It's too easy to pass up and too reassuring when someone gets good scores. Next, the interview. Okay. So this is your opportunity to demonstrate that you will be a valuable member of your team. They are interviewing you. They already are pretty sure, unless you come there wearing a clown suit and act a little crazy, they're pretty sure that you're qualified, that you're smart enough, you've shown the ability to learn, your letters, your transcript, etc., get you through the door. But now you're going to interview. So these interviews all involve either individual or group interviews with faculty, often other residents. I've taken part in many of them, both for internal medicine and for intensive care. They all include significant time spent with residents. Sometimes it's the evening before the interview, and the residents, everybody goes out to dinner, you and some other applicants, some of the residents, maybe an attending or two. More often it's during the day, and you spend time with the residents, you eat lunch, you may round with one of them, and the residents are there to tell the program director, we like this person will fit in. This person will function well as part of our team. Surveys show that the residents' strong impression of candidates, if it's very positive or very negative, is very impactful. It's very impactful. It's not like time for you to relax and spend some time waiting for your interview someplace else 2 days later. This is an important thing. My rules of engagement, as I like to call them for the interview, once again, by the time you get there, trust the system, feel safe, be yourself, answer all your questions forthrightly and openly, okay? Don't introduce subjects that are likely to be controversial. I wouldn't be there making a political joke or anything like that, but if somebody asks you, you answer them. Okay, be prepared to answer questions regarding any weaknesses on your record. I will tell you as an interviewer, this is something I always wanted to know about. So I might say, I see in biochemistry, you seem to have had a great deal of trouble. Your other grades were much better. What went on with that? And do I really care why that person had difficulty with biochemistry? I might be curious, but I'm not really interested. What I'm interested in is how that person deals with something he did not do well, how that person deals with a mistake he made. So if you take anything home from this, take this home. When you're asked about these, and you're likely to be asked about weaknesses on your application, or you will be asked a question like, tell us about a time you had a conflict with another student or an attending or a patient or a patient's family, and how did you handle that? You are always honest answering these. Offer a brief explanation if there is one for why things didn't go your way. Don't spend a lot of time on this. Don't involve people, for 3 minutes in this part of the answer. Nobody's that interested. briefly what was the problem and spend your time emphasizing what you did to recognize it and correct it. Talk about the changes you've made. This is your time to show people that you're accepting of the fact that you can make mistakes, other people make mistakes, and what you're most interested in is moving on in a positive direction. Okay. So before you go to your interview, review your application the night before or that morning so you know everything that's in it. So you may have made a casual statement in your personal statement that you've forgotten that you might be asked about. I always ask people about their personal statements. Okay, next. Take-home messages. The application process is changing and complicated with many moving parts. If you can begin shortly after entering medical school and accelerate when you figure out what specialty you want, that's a good thing. You don't have to decide early. Many people who decide early change their minds. The great American golfer Ben Hogan said it's never too early to start winning. That's true, but this is a marathon. I'm not trying to pressure you. I'm only saying the earlier you can decide, it does give you an advantage, okay? Do understand that IMGs compete at a disadvantage, and that with this pass-fail business, that disadvantage may be more than it was. Understand, high achievement in medical school, passing those tests, learning all that material, being able to be a great doctor in that way, that's a full-time job. Don't be afraid to seek professional counseling and this other thing, a lot of which is about form rather than function and is much harder for you to know and recognize on the spot. And the thing I would advise you most strongly is don't mistake me for telling you that you should design your medical school career to create a strong application. That would be a mistake. What you want to do, though, is gain the ability to look at your experiences from the outside, from the lens of a program director of a training program, to recognize what in that experience they would like to know about, and frankly makes you look the best. Next slide. Okay. We're almost done with the marathon, right? Both this talk and the application we're creating. Okay, now you're going to enter the match. You're going to submit a list of programs in order of preference. The programs are going to do the same thing. The match provides an impartial venue. This is a quote from the match program themselves. Okay. The algorithm is applicant favorite. I don't want to spend a lot of time on it, probably because I might not understand it as well as a really good mathematician. I was okay with math, but there were some people who were brilliant at it. But basically they have a computer to look through 40,000 applications and ask the question individually. Let's look at Alka's application. She lists NYU number 1. NYU has 5 spots in her specialty, pediatric neurology. She is ranked number 5. If she's ranked NYU number 1, that means she's guaranteed a spot. Boom, 1 spot at NYU is now gone and it belongs to Alka. That's how it works. So it works in preference of the applicant. Please realize the match is a contract. It's binding. Okay. If you match to a program, you are going to that program. I have known a couple of people who have matched and then sought an opportunity outside the match. That does not end well. Okay. Next. Okay. You'll see in a circle, if you can read it, the match rate for non-US citizen IMGs, which is the audience I'm speaking to, was about 58%. And there it's listed over on the left. USMD seniors matched at about 93%. DO seniors matched a little lower than that. Failure to match often results from ranking too few programs, kind of a sign of overconfidence or laziness. The fact that the slots you've listed way at the top are highly competitive. meaning that you've misjudged the quality of your competition or the quality of your application. Another one is that your interview, your visit didn't go well. You didn't recognize that. That's easy. That's an easy mistake to make. Sometimes the candidate ranks many programs, but ranks the least competitive programs lowest. And then if other people of comparable quality have ranked those least competitive programs more highly, they fill up with those people and that candidate gets lost. In short, it is very, very important for you to perceive the strength of your own application. I'm going to tell you that's not easy to do. And if you're finding it difficult to do, which I think most people would, counseling in this is very important. So you can create the right match and you can match up. Next slide. Okay, boy, this slide got killed. Okay, so the take-home message is things I've already said, and seeking help in knowing what you're doing here is a really smart idea. Okay, next. Okay, what happens if you don't match? The match box is empty. Okay, there is the supplemental offer and acceptance program, the SOAP. Okay, it is available if the match comes out on Friday, which it usually does, I think, or Thursday. The next week, the first 4 days, are this SOAP, which is an opportunity for applicants who didn't match to get in touch with programs who didn't match. There are 4 rounds of those two matching, and many programs that didn't match and many applicants that didn't match wind up filling in this. Okay, next. Okay, how about this for colors, huh? Okay, so this is a little test for those of you who have to remember the electromagnetic spectrum going red, orange, yellow, blue, indigo, violet. Okay, with green in the middle, what we used to call Roy G. Biv in this country, probably still do. Okay, programs that are listed in red, okay, are hot programs. They're the hardest to get into, okay? So if 90 to 100% of a program's slots are filled by American US medical graduates, those are programs that are red. The next right down, red, orange, yellow, green, blue, violet. Okay, so you'll see a violet program is one that has fewer than 60% of slots filled by US medical graduates. Internal medicine, for example. Then next to that, and you'll see the number of slots. So this is a slide you've seen before, but now it's colored in. So next to that in parentheses is the number of slots open. This is the 2022 match. This is the match that took place a couple of months ago in March. Okay, and then the last percentage number, you will see the percentage of spots that are filled by international medical graduates. So just to make sure we all understand each other, and I know it's a complicated slide, probably could have done this one better. I don't like it. Next time I give this, it'll be a better looking slide. So let's look at number 17, pediatrics. There are 2,937 spots. Okay, it is a green program, meaning that 70 to 79% were filled by US medical graduates. 7.5% are filled by international medical graduates. You can see very difficult programs, dermatology, 0% foreign medical graduates. Okay, now, before you despair over this, if you are have lived your whole life wanting to be a dermatologist, okay, there are a minimum of 4 different articles written in the past 2 years in one of the 3 key journals for American medical education that are titled a variation of Looking at IMGs as Neurosurgery Residents was one of them, okay? And each one of them describes the performance of international medical graduates as every bit as good as American graduates. So if you attended the first webinar, you would know that international medical graduates within the US medical system have traditionally filled the role for underserved areas, specialties that nobody else wanted, or specialties that other people kind of like, but now you're in a place that most other people didn't want to go. And what I'm saying to you is that this is changing. It's going to change very slowly, but you are entering, if you're applying for residency and you want to practice in America, you are entering a time where the opportunities are going to be greater for you than they were in the past. And that's something I really want you to remember. Next. So this is a list of useful sites for you to go to. There's lots of information there for you. And I would urge you to keep this list and use it to optimize your opportunities. And that's webinar number 2 for me. So I am open for questions for those of you who are still awake and with us. Dr. Deoras, what do you have for me?
Yes. So thank you very much. It's a really excellent webinar. And I think students must have got insight into the complete application process, the step 1, step 2 CK, OET, 3 examinations. Definitely all the Indians has to take these examinations. And with such an experience about the letter of recommendations, the resume preparation, application parts, and very, very important tips were given. So students, let's take the question answer sessions. Please start typing those who are more questions onto the question and answer tab. I will take one by one question, and then Dr. David Kaufman will answer the questions. So I will take the first question. So how exactly to ace up your profile on CASPA to make it competitive and increase the chances of getting selected for the PA program? And now this is actually for the residency part of it. So we will skip this program for this question for now. We are taking on to the residency seminar. So we will take the CASPA questions separately, not in this. Another question is, what is the mechanism of assessment of residency students? What is the mechanism of assessment of residency students?
Okay, are we talking about people who are in residency or people who are applying for? I don't know what
applying for the residency. Yeah.
Oh,
what is the high level criteria for the residency admission?
okay, that's a great question, and it's going to vary from program to program. Okay, mechanistically, what happens is applications are received and a certain number of people are asked to review those applications, okay? And those people will be asked to choose whom they would there's really going to be, each reviewer of an application is going to have 3 piles, if you will. One pile is, we don't want this person, okay? For whatever reason. We don't want this person. In my opinion, this person isn't going to be here. How would that come about? Oh, a program that knows it's highly selective and, a very highly ranked program, and frankly sees someone who has failed the step 1 exam twice. That person's not going to get interviewed. Someone who had very poor grades had to repeat 3 courses in medical school. That person's not getting interviewed at that program, because whoever reviews that is going to put them in that pile to the right. We don't need to look any further at this person. Then there's going to be a pile at the left, which is, we really want to look at this person. So, for example, this is a research-oriented program, a highly academic program. That applicant is passed, and that applicant has I'm just making stuff up, has a PhD in bioengineering, has just completed medical school, has 3 patents that they have on things they've created. Everyone got good grades, passed the USMLE. That program is going to want to interview because that's what that program is looking for. Someone who's going to graduate from that program, do great work. Do great work based on their research. It's a research-oriented program. And then in the middle are going to be, yeah, this person looks good and would probably do well in our program, would function well as a teammate to our residents, appears to have the kind of values that we favor, has done well in school. The dean says everybody likes them, but 70% of our applications or 60% of our applications fit in with this. So that's the middle pile. Then that group of reviewers at a good program that has active reviewers, those same applications in different order are going to be given to another reviewer. Okay. So everyone who gets that must interview by two different reviewers, they're getting interviewed. Everybody who gets do not interview by one or two isn't getting interviewed. And then there's everybody in the middle. They'll be given a numerical rating or a verbal rating. There's some language within the program. And then those reviewers meet in what always is a painful meeting. I assure you, it's painful. It takes forever. Everybody goes on, just like you've heard me go on this morning about this candidate or that candidate. And that part of it is going to be worse now because it's going to be worse as long as there are no scores, because scores are the great objectifier, right? Here's a number. You can say what you want about that candidate, but this one got a 262 on the exam and nobody else did. That's 90th percentile, etc. So the group meets and selects who's going to be interviewed. And if you think this sounds vague and there's a lot of subjectivity, that's my point. It is. There is a lot of subjectivity because everything that's not a number in this application is subjective. Once that person is going to be interviewed, then everybody who takes place in the interview of that person gives them a rating. At the hospital I was interviewing at, you'd rate that person 1 to 5. Okay. And that was the other residents that met with them, the interviewers, etc. And then those people, they would start, if 5 was the highest you could get, they would start with those who got the highest totals. There would be a 4 or 5 hour meeting one night, and that's a painful meeting to create the rank order list. I'm hoping I'm answering your question. If I'm not, give me a clarifying question. I'll be happy to do my best. But it has become a highly subjective process.
Yeah, that's right. Yeah, the things with USMLE Step 1 becoming a pass fail is going to be a different world. So if it is, we need really a great profile part of it, and really a great your showcase into other than the USMLE. You have to showcase a great deal. How do we grade the skills that the doctors acquired? How do we grade the skills? So,
are we talking about in medical school?
Yeah. So, what skills they have acquired during the medical school? So, how those skills will be graded for the residency admissions? Or
okay. So that's a fantastic question, because really, this is terrible because I hate when people do that to me. It's a fantastic question and there's no answer to it, but let me explain. That's a fantastic question. But understand that when you ask that question, implicit in the answer to that question is that there has to be a methodology for evaluating that. Okay? So once again, let me broaden the question. And this is something I spend a lot of time talking to my colleagues and administrators about. How do you know somebody is a great doctor? How do you know that? If I were to say to you, I'm a great doctor, and you said to me, prove it, how would I prove it to you? Okay, number one, it would depend on what you valued. Is a great doctor one who's very empathetic? I can tell you I'm not a very empathetic person, but I think I'm a pretty good doctor. Is a really great doctor one who can make the diagnosis quickly and accurately and not test for things that we don't need to test for? In my mind, it is, but try to quantify that. Try to show somebody that that's true. You have to have the data. And for everything but medical knowledge as displayed on a test, once again, for everything that is not your knowledge of medicine displayed by a test score, everything else is subjective in the way we measure it now. So I think that answered your question, but didn't answer your question because there is no way to know that. Now I'm going to answer it a little differently, and we'll move on then to another question. What makes you a great doctor? I'm not talking about surgeons now. Surgeons, you have to have these. You have to have great hands. You know, your hands have to learn to be great. You're a craftsman when you're a surgeon. You're not a craftsman when you're an internist, okay? What makes you really great is your ability to listen to a patient, your ability as you listen to a story to pick out the elements that don't fit, that don't make sense to you, because it's those elements that tell you when it's something other than the usual is going on, and you better pay close attention. So when someone tells you, I'm having some nausea, okay? But it doesn't seem to matter what I eat or whether I eat at all. I'm nauseated all the time. And it's funny, but I think I'm more nauseated when I lie down than when I sit up. Okay, you're going to hear a lot of patients complain about nausea, but the one who just said it that way is the one you have to say, has your vision been blurry? Do you have a headache? Because that patient is telling you, I have increased cerebrospinal fluid pressure. That's why I'm nauseated. It's not because I'm worried about my daughter because I think she might get pregnant or whatever. So it's your ability to listen for nuance. It is your knowledge of the guidelines as they've been written, the science that underlies those guidelines, and then it's your ability to apply those guidelines to the individual patient. So in short, it's your ability to make a diagnosis by listening, by being thorough in your exam, by being confident, okay? And then it's your ability to say, okay, here's the behavior of this test that I can do, but here's how it would apply to this patient, so here's what I should do. And that, for me, what makes you a great doctor. Making you a great primary care doc, you want to be we'll change that. You want to be a great endocrinologist? Most great endocrinologists aren't great because they're the first ones who can spot the tumor in the hypothalamus that's making a hormone that the rest of us forgot about. Okay, that's not what makes you a great endocrinologist. What really makes you a great endocrinologist is that you're a great coach, because most of the patients you're taking care of are diabetic, and you have to get them to eat properly and exercise properly. And if you think there's anything difficult, try doing that. Try taking the patient who's 275 pounds and getting them to lose weight without doing bariatric surgery. So that's what makes you great at that. So I don't know if that answered your question. It was a very personal answer. I can't document that in the literature or anything like that, but that has been my experience.
Another question. When do we write USMLE Step 1? During medical school or after the internship? What is the right time to give the medical schools?
USMLE 1?
Yes.
That has to be on your application.
Yeah.
So your applications are going to go out in July of your senior year. So you have to know that by July or August, that score is going to be available. And it shouldn't take more than 6 weeks to generate your score. But understand, if you do it that way, you better be pretty darn sure you're going to pass, because if you fail, that's the last time that year you can get it on your application. So I'll bet anything that Dr. Deoras has better advice than I do, but it would seem to me, two things would seem to me. Number one, it's really going to depend on whether you're going to take step 2 that year and have it on your application. I think if you're a strong candidate, if you're a really good student and you know your stuff, you want to have both step 1 and step 2. So I would take step 1. I would probably take step 1 in January, have it in February, know if I passed or failed. If I failed, I would have a chance to take it again then in July and demonstrate a passing grade. If I pass, then I have an opportunity to take step 2 exam and do well on that. What I'm going to tell you is pass, fail, step 1 and step 2, how do I say this in a nice way? I'm not going to say it in a nice way. They pretend that they cover different areas. They're pretty close. They're really pretty similar, those 2 exams, surprisingly similar to me. So to summarize it, what I would do is you're done with your 3rd year. I would schedule my 4th year. So I took my major rotations first, especially rotations in which I was interested in what I was going to do. You know, I want to be an internist, take internal medicine first. And if you're interested in a subspecialty, take that next in your senior year if you're able to do that. So have the subjects you're most interested in, but has to include internal medicine and probably general surgery in the first half of that year. January, I would take step 1. As soon as I passed step 1, I'd be ready to take step 2 in July. But remember, I'm talking about a medical student who has supplemented their time in lectures and taking the exam you take by keeping up in board review books. So the whole time you're in medical school, you're preparing for those 2 tests, which is essentially preparing for 1 test. Okay, because they cover the same subject matter. I hope that answers your question. Dr. Deoras, please comment, because you've been counseling people in this for a long time as to when, and I'm not really great at the timing of things, but that's my sense of the timing.
No, that's perfect. Only thing what I want to tell the students is in United States, the Doctor of Medicine program is the 4 years program. So when we talk about the 3rd year and 4th year,
okay,
it is not the 3rd year and 4th year of Indian system. So in India, once you complete the 6 months of the internship, when you have the decent level of patient exposure, because as the Dr. Kaufman has said, there are questions which is based on the diagnostic part of it. Unless you have the exposure to the patient's part of it, it is very, very difficult for you to pass the USMLE Step 1 and Step 2 CK examination. So my recommendation is always, once the 6 months you complete, you take the Step 1 exam, you complete a whole internship part of it, then you go to USA for 2 to 3 months of rotation in a hospital. You understand the US hospital system, the diagnostic system in US, and then you take the USMLE Step 2 CK and the OET exam. That is the best timeline part of it, so that your chances of passing the USMLE Step 1 in first attempt also increases. Just understand the USMLE, if you pass 7 years, you cannot repeat. So even in the Step 2 CK, when the Step 1 marks are not visible, now the pressure is on the Step 2 CK. In case you get less marks in Step 2 CK, you are in a problem. So that is why you need to be very careful, because 7 years you will not be able to repeat that particular examination. So that's the best timeline into that. Any other questions which are there? One more question which is there, which I think already Dr. Kaufman has answered in detail, but I will just still maybe a small comment from Dr. Kaufman. The student is again asking, now the 3-digit score of step 1 is not available now, pass and fail. And so in that case, if the student who has already taken the USMLE Step 1 earlier, scored good marks like 256 marks, will have the preference over the subjective aspect. But somebody has already taken the Step 1 when the 3-digit score was there, and he is now applying now, he will be benefited as compared to somebody who has taken just pass and fail?
Okay, that's a really good question. So let me start out that question with a statement that I usually make when I give lectures, which is that information is only as important as the source. Okay, so what I'm going to tell you is I don't know any literature on this. I've looked for it, but I haven't been able to find it. So this is personal, professional opinion. Okay, so that's what you're getting here. You're not getting the facts. You're getting my opinion. Looking at it from the viewpoint of a program director, I have an applicant, okay, and I would urge you all to remember, I am very plain in my speech. I'm a program director. I have 12 spots to fill. I have 100 applications. 90 of them are from medical schools that I'm familiar with, may have people I know. One of them may be a medical school I graduated from. And then I have 10 that are coming from medical schools in a country I've never visited that I don't know much about. I am going to be biased to what I know versus what I don't know. That's just a reality of human perception and human existence. Of those 10 students, and we'll say they're all coming from Indian medical, if I see a number like 248, 260 on a step 1 exam, that answers all my doubts, not all of them. Now I have no doubts that that student has been able to absorb all of that information, has been able to take that information, correlate it in a short clinical case presented to him, and choose the right answer of 5 answers. I'm pretty confident this is someone who really is easy to educate, who's very smart, and who's fulfilled the first purpose of medical education, which is to learn how to do that. So I think if you've got a good score, that's an advantage that can't possibly be matched by someone who comes in who just passed. That's my opinion. Dr. Deoras, you think? Same?
Yeah, definitely. If you are a good score, because then definitely it has been advantage. The only problem was it was a big risk. If in case you are not able to score good marks, again, you are stuck with 7 years, and that is going to be disadvantageous. So if you had a very sure earlier, now that milestone has passed, today you don't have choice. This is maybe for the old students who have already taken, but today you don't have the choice. It is a pass and fail. There is no numerical score. But if you got a good score, definitely it is advantageous. I fully agree with Dr. Kaufman. There is no question.
Let me say something, okay? And I'm actually confident that this group of medical students is a group who would better understand this than possibly American medical students, frankly, who've grown up, many of them with a lot of privilege, certainly many of them that I went to school with. This is a tough business, guys. It's a tough business taking care of sick patients. It's a lot of responsibility. This business in your application, these tests, these are high stakes items. To put it in gambler's terms, there's a lot of money on this. There's a lot. These are high stakes. They're not easy. They're not things that if you don't do well, it's really okay. All right. So these are high stakes. Your whole application is high stakes. So what I'm going to say is spend your time focusing on these things. That's why I've said over and over again, you begin studying for this exam the day you enter medical school, the first day of your lectures, you're preparing for this exam. As you're looking at your experiences, as you're choosing what to do for your research project in medical school, you're looking at this. If you want to practice in the United States, you're looking at this through the eyes of a program director and saying, okay, what skills can I demonstrate doing this? what do I have to say about this? All I can tell you is it's a tough world. It's not easy. It would be nice if everybody passed and everybody got a great score, but it's not like that. On the other hand, you will be rewarded for your close and careful work if you do it. And, in this world, if you get rewarded for the hard work you put in, I don't think you can really ask for a lot more than that.
Yeah, thank you very much. It's really a great insight. And I think even the question answer session, what Dr. Kaufman, it is coming from his so many years of experiences. And you can see the passion and which he has answered every question and even conducted the complete webinar. He strongly believes in the value system, professionalism, and one great takeaway which you can do, be yourself, what he was talking about: genuinity, professionalism, ethics, passion, and be yourself. Don't be showing something who you are not. So that's really a great, because that will genuinity. US professional, it's a very noble profession, and they want really genuine person who are really wants to serve as to the society, treat the patients, and be a highly professional. I'm really thankful to Dr. Kaufman for giving such a wonderful taking session and the question answers. And so we have answered most of the important questions which are there. We are very, very happy. We will pass on this to all the attendees which are there. We will be very, very happy. I am also invited Dr. Kaufman to visit India, and we hope we will be finalizing the date soon of his visit in India. He will be visiting many medical colleges, and if you are interested, Dr. Kaufman, to come to your medical school, please do connect with me. We will be making a proper schedule of that, and he loves to interact with the students in India. He wants to understand our medical system into that, and it will be a great value addition to the students and the faculty and institution, which such a great personality is visiting India and interacting part of it. Is one of the best in the New Jersey, and the professionalism what brings to this profession is something phenomenal, and really astute. And all the students, I'm really thankful for Dr. Kaufman for taking such a wonderful session, and something we will definitely cherish for long. Thank you very much, Dr. Kaufman. Anything you would like to add?
Well, listen, thank you, and thank everybody for hanging in there. I'll make one more statement. The following two things are true of everyone at my age. Okay. We all want to tell our story. So I love to tell my story. And we all are looking for the fountain of youth. And the fountain of youth is to spend time with young people. So I can't tell you how much I'm looking forward to visiting your country. I hope I get to meet all of you and spend a lot of time listening to you, because there's a lot I have to learn about what goes on over there. I kind of know what goes on over here. So thanks for listening, and I look forward to meeting you.
Yes, thank you very much.